Hey, Omar, I see that you joined.
Hey Lisa, how you doing?
I'm good. How are you?
Good.
Good.
Should I test this out?
Yeah, I wanted everybody to join. I know we don't start till 12:30, but I thought it would be good to join early just to make sure everything, flows correctly. And then ISD is going to be joining us early as well.
Okay.
So you can share your screen. So did you try sharing your screen, Omar? Share content?
I'm getting ready to now.
Oh, okay.
Had a call on the call line. I'm trying to get off of that too.
Oh my gosh.
Yeah, it's been a busy day. All right, let me get off. Oh, here you go.
I see it. And then you'll want to go to, there you go.
Hold on, this is chat. No, I'm getting stuck with CME.
Say that again. Oh, can you go back to the first slide? There we go. We'll start. Just leave that one up for when people join. And then I'm going to be just reading a script. But when I mentioned that I want to introduce today's speakers, you could go to the second slide.
Okay. So you can see. So how long does it take for you to see like slides? Is it instant?
Immediately. Well, so go back to slide 1 and now change. Now I see slide, wait, now I see slide 1.
I'm going to change it now.
And now I see slide 2.
Okay. I'm going to change. I meant to. Well, does it matter? Should I change Dr. Miller's and make it professor of like Dr. Eron's?
I don't know. That's the way they sent their information.
Oops. Okay. Does it matter? Is it different? Should it be the same?
I don't think it matters. I think just because since that's the way they worded it themselves, we could leave it. I meant to take off those.
Do you see any? Do you only see the slide, or do you see any of the WebEx stuff?
I just see the slide and a picture of you. The picture of the person talking will be shown. And yeah, let's see.
So if I'm not talking, you don't see a picture of me?
Well, I think it depends on how I do my view. Let me see one thing here. I'm sending you a picture of what I see.
Okay.
What's your, is it 784-4468?
No, it's 31600.
Well, is it 919?
Yep, 919-316 0053.
Okay.
Okay.
And right now I'm seeing like you're maybe hovering over something at the bottom that shows last. There you go.
I was, yeah. Cool. All right. Is there anything else that you can think of that we may need to?
I think so. You're going to be just focused on changing the slides. Bonnie and I, she's going to be, so Keith is going to be on and actually take over the host capabilities. I see he just joined, to mute people and everything. Bonnie is going to monitor anybody with names that go A through L to see if somebody's talking. She could shoot them a message or shoot Keith a message saying, hey, this is who's talking, and I'm going to monitor M through Z. And I'm going to be, doing that introductory script, but
Lisa.
And so, Omar, I think once the actual program starts, I think it'll be fine for you to mute yourself too. Because you're not going to
Lisa,
have
can you hear
to
me?
talk. Hey, Matthew.
Lisa?
I barely hear you, Matthew. Or is that Keith?
Lisa, it's Keith, can you hear me okay?
Oh, now I hear you. Keith, do you want me to switch the host over to you?
Yes.
Okay. I can barely hear you for some reason.
My love is here.
And so the one showing right now, Keith, that has your headphones showing on it, that's the one, that's what I should be switching to host.
Yes, I didn't connect with my phone this time. Can you hear me any better?
Okay.
3, 4, check.
Yes, that's much better.
1, 2, 3, 4. Okay.
Yep.
Thank you. Will anybody be on camera in this particular presentation?
So yes, we will just have the two speakers unless they don't want to use their camera, but we'll allow them to use their camera.
Okay.
And that will be, they'll join early as well, but that'll be Dr. Eron, Joseph Eron, and Melissa Miller.
Great. Okay. That was a good script you read this morning.
Thank you. I've got basically the same thing with a little bit more information this time.
That's customary, you know. I'm on a lot of the leadership meetings where there's a large number of attendees, and they always read that, something like that, you know.
Mm-hmm. Yeah. I think we're gonna, as the series goes on, we'll read the same thing every time. People will probably get tired of hearing it, but it's a good reminder. Hey, Omar.
Yes.
Can you change, I'm just realizing on that top slide, can you take off questions will be answered following each presenter? I think we're actually going to do all the questions at the end. But if Dr. Eron asks somebody for questions at the beginning, we can take them, but I think we're going to try to do all the questions at the end.
Okay. Hold on, let me.
And if you can't, that's okay. I'll just say that. Hey, Matthew, you may want to have that email open because as people go, like get closer to 12:30, they may realize they don't have the WebEx start sending emails to that email if they weren't paying attention.
Okay. Is that good, Lisa?
Perfect. Hey, Dr. Miller, I see you have joined.
Yes, I'm here.
Thank you. And we combine your slides with Dr. Eron, so everything will be ready when it's your turn, and you can just tell us next slide.
Great, thank you.
Lisa?
Yes.
Just testing audio.
Hi, it's Joe.
Dr. Ron.
Oops.
Hi, how are you?
Good. How are you guys?
Good. We've got I think we have everything up and ready to go once we get to 12:30.
Okay.
So we'll have you, Dr. Eran, go in first, and we can advance your slides
Okay.
when you tell us to.
Perfect.
Thank you.
I see Dr. Miller is here.
I am
Yes.
present.
What? It's funny how much we work together, but we never.
I know.
Crazy.
It's all kinds of crazy.
Yeah, right. That's for sure. Hey, Dave.
Good afternoon. Somebody's typing. Could you mute your mic, please? Thank you.
Good afternoon, everyone, and thank you for joining the UNC Rex Heart and Vascular Grand Rounds and the UNC Health System Network Development and Physician Relations Virtual COVID CME Series. My name is Lisa Moore, and I will be your host for today's session. We intend for this WebEx to be highly informational. To that end, we ask that everyone remain muted throughout the entire presentation. We're monitoring the chat feed carefully. If you will use the chat to everyone feature, we will monitor your questions as they come in and answer them at the end of the presentation. It's our experience that the audio feed is slightly improved if everyone, with the exception of the presenters, will turn off your video feed. So please take a moment to turn off your video feed and also ensure that your phone and audio are muted. To ensure that you get CME credit, you must have a registered MyAHEC account, and we will also need your full name if that is not displayed in the participant list. Please send your full name in the chat if it's not correctly listed in the participant list. This afternoon, we'll be discussing the treatment, vaccines, and laboratory updates for COVID-19. We'll be recording the session and it will post later on the Physician Resources page of UNC Health. However, the recorded version of the program will not be eligible for CME. To that, I'd like to go ahead and introduce today's speakers for the presentation. We have Dr. Joseph Iran. He's Professor of Medicine of Infectious Diseases with UNC, Chief of Division of Infectious Diseases, Director, Clinical Core, UNC Center for AIDS Research, Associate Director, General Clinical Research Unit, and Adjunct Professor of Epidemiology with the Gillings School of Global Public Health. After Dr. Iran's presentation, we will have Dr. Melissa Miller. She's Professor of Pathology and Laboratory Medicine and Director of Clinical Microbiology and Molecular Microbiology Laboratories. So, Dr. Iran, we'll go ahead and turn it over to you.
Great. Thank you. I hope you all can hear me clearly. I appreciate this opportunity to talk to people. I'll actually probably go pretty quick to leave time for Dr. Miller and hopefully time to answer questions too. So I think people know on this call that COVID-19 illness has a kind of a broad array of clinical presentation. Most people, 80% or more, have relatively mild illness, and only about 20% of people who get infected actually are sick enough to come to a healthcare or hospital setting, and some maybe 15 to 20% of people end up being admitted to the hospital, and then a smaller fraction, half of that, 20%, end up in intensive care units. At our hospital, at the medical center, more than half of the people are in intensive care, in part because we get referrals from outside hospital. The symptoms of initial COVID are those of a respiratory viral infection. Most people eventually develop fever, though only about half of the people have fever initially. And certainly cough and shortness of breath are common. One symptom that turns out to be pretty specific is kind of loss of taste and smell. And that may have to do with the both local and maybe even central nervous system reaction to the infection. But people can have an array of symptoms. We've had people with nausea and vomiting. We've had people with diarrhea, and is quite a range. Most people who end up being hospitalized get hospitalized because they're short of breath. Though in older people, we've had people, admitted for confusion or differences in consciousness, but that's it is predominantly a respiratory illness. So there are a lot of consequences, including hematologic coagulation related to COVID, and I can answer questions about that at the end. Slide. So these are data from New York City. I hope I'm on my laptop, so they're a little small and I have the chat open, but people that have hypertension, coronary disease are at higher risk. Interestingly, people with chronic respiratory diseases are at somewhat higher risk, but not a lot, maybe not quite as much as you would have expected. And the other risk factor that wasn't really predominant in China, but is here, is obesity. I think almost all, but not all, of the younger people in their 30s and 40s that I've seen in the hospital have had obesity, and some, morbid obesity. And again, from New York. And then, illness severity is really, proportional to age, and the risk of death is very much proportional to age. And you can see that on the right hand at the bottom of the slide, looking at, kind of the proportion of people discharged alive. When you get in your 70s and 80s, it's in men anyway, it's about a 50% chance of being discharged alive, meaning 50%, don't make it to discharge. Women, for some reason, are less likely to die than men. And this was also seen in China. It's not 100% clear. It may be that men have more risk factors than women. None of these, what I'm showing you here, really is a multivariable analysis. And those analyses will be done, but men are certainly at greater risk of dying than women. Next slide. So this is a CT scan of severe lung disease. You can see a couple of features. One is that you got kind of filling of the air spaces, and obviously that explains the air hunger and shortness of breath. It's usually pretty patchy. You can see some normal areas of lung. If you go to the next slide, what we don't really understand is why some people look like the first CT scan and get incredibly ill and end up on mechanical ventilation, and some people look like the second scan. The bottom, the right lower lobe and left lower lobe, you can see those kind of patchy, same kind of hazy infiltrates, except for there are just a few of them. And this person actually came in for abdominal pain and got a CT scan for that reason, and was then subsequently diagnosed with COVID-19 and actually went home. Clearly had, but obviously much less severe. And if you look at chest X-rays, you'll see that there's quite a bit of patchy appearance to the X-ray. Next slide. So this is a little different than influenza. You know, if you talk to someone with influenza, maybe they have a day or two of prodromal symptoms that are mild, but then they usually say, I got sick, you know, yesterday at around midday, I started to feel feverish and sick. And that's not what we see, at least for most people with COVID. They tend to have a much slower progression of symptoms, and the time from onset of symptoms to hospitalization on the order of days or even longer. What sort of breath, respiratory failure very, very quickly. We've certainly seen frequently seen people show up to the emergency room short of breath and end up intubated in the intensive care unit, 6 or 12 hours later. And the hospital stays once on mechanical ventilation can be incredibly long. The consequences of having COVID illness include a kind of unusual coagulopathy. There probably is kind of microcoagulopathy in the lungs, but we've actually seen macrocoagulopathy. There are reports of stroke. We've had several patients that have had pulmonary emboli. One in particular was actually recovering from their kind of respiratory infection and developed pulmonary emboli. So there is a abnormality that's associated with COVID-19. Next slide. So there are clinical features of the more severe disease. You can see higher C-reactive protein. D-dimers can be remarkably elevated, which is a measure of vascular thrombosis. We've had people with D-dimers in the 34,000 range. People who are sick tend to have elevated ferritins and fibrinogen, other inflammatory markers, and can have a low absolute lymphocyte count, though honestly I've not been as impressed by that. And I've already gone through some of the comorbidities. I may have failed to mention diabetes, but that's clearly a comorbidity that leads to substantial risk. Next slide. I don't know if any of you know this website. It's a terrific website. It's from Johns Hopkins. Look, you can see, number one, it's a pandemic because there just is incredible disease everywhere. This is 2 days old, and there were 7 million cases, diagnosed cases, right? Confirmed cases. There's probably 3 times more than that, if not even a bigger number. I suspect if we went to this website right now, we might find, 500,000 global deaths. In the U.S., we've got 2 million confirmed cases. Again, I think you'd probably multiply that by a factor of 5 or more for actual cases. And Melissa might have some thoughts about that. And we have well over 100,000 deaths in the United States. Next slide. This is looking at what's happening in the United States, and obviously the United, bunch of different smaller kind of epidemiologic units from like New York City that had incredible death rates and account for those spikes in April, to North Carolina. And in New York, I saw this morning there were a total of 35 deaths in New York State total yesterday. In North Carolina, it's very different. We're not in a peak and trough. We're in more of a constant level of infection. The number of people hospitalized has been about 600 to 700 in North Carolina, and Last week, we had several days greater than 700 people hospitalized, which was the highest levels that we've seen. And the number of new cases in North Carolina really has not gone down. It's gone up. Some of that's due to increased testing, and Melissa will talk about testing. But I think also we don't see a waning of infections as yet in North Carolina. Next slide. COVID is now, this is a slide. It's funny. I think it's like 4 weeks old, so it's an old slide. I suspect COVID is the #1 cause of death now in the United States, as opposed to the #2 cause, which it was when this was published in the Washington Post. And these numbers are probably underestimates of the mortality related to COVID, because it's certainly not all counted. Next slide. Here's North Carolina. On the right is just cases in the county. This is, I think, about a week old now. And you can see that it's obviously spread throughout the state, and most counties that are have a smaller population have fewer cases, but not all. You can see that one county right around Goldsboro, that's Wayne County. They've had over 1,000 cases in Wayne County. I think about half of them have been in the prison there. And you can see Wake, Durham, and then I think Forsyth, and then the counties around Charlotte. If you look at the death toll in North Carolina, it looks like it's dropping off, but I think that's a reporting phenomena. I don't think it's dropping off. You know, these maps are available through the DHS here in North Carolina, and really are updated daily if you want to go take a look. Next slide. So why is SARS-2 or SARS-CoV-2 such a problem and so transmissible? I was just listening to Dave Margolis talk just a little bit ago, and he pointed out that sometime probably around 6 months ago, maybe a tiny bit longer, maybe 7 months ago, one person was infected from an animal in some way with two. And now probably there are 10 million or more people infected around the world. This graph is looking at shedding, and Melissa will talk more about this, but basically the farther to the left you are on the graph, the higher your virus titer. This is all measured by PCR, so the fewer cycles it takes to detect the virus, the more virus there is there. This comes from the University of Washington in Seattle, and they were just looking at influenza samples that they had, because when this came out, you know, obviously there was influenza at the same time as COVID. And what you can see is just, at least from nasal swabs, the titer of virus with SARS-CoV-2 in the nose is incredibly high. And so in the upper airway, and I'm sure with my talking, the front of my computer is full of airborne, full of respiratory droplets now from just me talking. And so you can see how you wouldn't have to be very symptomatic to spread COVID-2. I did that, and then I shook your hand. You would be at risk if you didn't wash your hands and you went and touched your eyes or rubbed your own nose. So it's not surprising that it's so infectious. And there's a lot of debate about asymptomatic. There unequivocally, people with infection can be asymptomatic. I think it's unequivocal that asymptomatic people could spread the infection. What we don't know is how infectious asymptomatic people are. In terms of, if they're not talking, like they're not coughing or sneezing, that you're not going to get across the room from them. On the other hand, they have very high titers. The other question that you could find data on both ends of the spectrum is, everybody who's asymptomatic, do they all become symptomatic? And there are studies that have followed people, and it's about 20%. There are other studies that have followed people, it's about 80%. So I think it's safe to say that most asymptomatic people do develop some symptoms, but probably the younger you are, the less likely it is that you'll develop symptoms. Next slide. All right, this is like a big message. It is a droplet spread disease. This is from actually some of our colleagues in Guangzhou, China, where they looked at spread in a restaurant. And basically there was an infected person, that's the yellow dot on the, that's a table and chairs in a restaurant. The yellow dot had infection, and the people around the table and the two adjoining tables are the folks that became infected. No one else in the restaurant. 73 other people at 15 other tables became infected. So if it was airborne, and you can see how air is moving, that's the air. Like if this person had varicella, for example, and everybody was susceptible to chickenpox, the whole restaurant would have been infected. So can it be aerosolized? Of course it can be in certain situations, but it's mostly droplet spread. Next slide. The title of this slide is Masks Work. This is another unit in China. It's an open ward unit, which they have in China. And in retrospect, there was a symptomatic patient with that red box where it says index case with severe pneumonia that turned out to have SARS-CoV-2. And there were 71 healthcare workers working here and almost 50 exposed patients, some of whom had close contact, but everyone had a mask. The patients had a mask, the visitors had a mask, and the healthcare providers had a mask, and nobody over a month of follow-up became infected from this person. So masks work, and the one message is you wear a mask to protect other people. If I had a mask on, my computer would be completely protected now from all the little droplets that I'm making as I talk. Next slide. And they probably also protect you, but they really do protect other people when you're wearing a mask. And this is just data from Italy, 2 cities in Italy, in northern Italy, that was devastated by the COVID-19 epidemic. The one on the right, Bergamo, in the Carolina blue, did not immediately introduce social distancing, and on the left, Lodi in the yellow did begin sheltering in place much quicker, not that much quicker, 2 weeks, even a little less than 2 weeks. And you can see the difference in cases between the 2 cities, which are relatively similar in size and are certainly in the same region. Next slide. So what about therapy? We have therapy, which is remdesivir. That's a polymerase inhibitor. It blocks replication of the virus. It actually blocks replication of a whole bunch of different RNA-dependent RNA polymerase using viruses. That's what we have. Lopinavir or ritonavir probably has some activity, but it's hard to demonstrate. It's probably not very potent. I think it's becoming clearer that chloroquine and hydroxychloroquine, if they have activity, it is modest and would have to be applied very early in the course of infection. We do know that we can make monoclonal antibodies. So these are antibodies that specifically bind to that spike protein that the SARS-CoV-2 ACE2, which is on the receptor, on the surface of respiratory epithelial cells, and actually a lot of other cells too. And these monoclonal antibodies will be tested. Convalescent plasma, so that's plasma from people who have been infected and recovered. We know that we've actually measured this at UNC. We've measured whether there's neutralizing antibodies within convalescent plasma, and there are. They vary by person, and we're studying that pretty carefully. Luther Bartelt and Dr. De Silva and Dr. Barrick are working together to test that along with Dave Margolis. Next slide. So what do we have? So I mentioned hydroxychloroquine. I think the evidence keeps, if you're hospitalized, it really is not really active. There was obviously a huge stir about that. I don't think for a hospitalized patient, there's any reason to give them hydroxychloroquine with or without azithromycin. Lopinavir ritonavir is an HIV drug. There was a relatively large New England Journal study in China that where there was activity, but it wasn't significant, which is slightly different. It didn't work. There were differences in mortality, differences in ICU stay. There's also evidence from China that lopinavir ritonavir plus ribavirin might together have activity. If we have remdesivir, I don't think there's any reason to use it. If we run out of remdesivir, we still are suggesting it here at UNC, but I will say we're probably the only center in the country that believes this. So you might check my bias. I don't have any stock or anything, but I looked at those studies very carefully, and I think there might be a little bit of activity. Next slide. I just have a few more slides. Remdesivir, there was a study from China where it basically didn't work. It had about the same effect as lopinavir ritonavir, to be honest. They're almost exactly the same. And it's not clear why that it didn't have much activity in the study from China. It was a smaller study, and it may be that there were some other reasons why it wasn't active. There was a lot of use of other antivirals in the Chinese study and also steroids. But next is the US study. So next slide, please. This is the very large study done by the NIH in the US and in Europe, which showed that on average, people went home 4 days earlier if they got remdesivir, and the mortality was reduced by almost 4%. In fact, when we get to the final data, it's closer to 4%. That's not a huge effect, obviously, but if you have 100,000 deaths, 4% is a lot of people. So it clearly has activity. If you go to the next slide, these are kind of time to discharge. So the faster the line gets to the top, the faster people are being discharged. And what you can see, if you go, A is overall, more people were discharged. You can see it's not dramatic. It's not like, huge separation, but it certainly was statistically significantly better. But as you go across to B, this is looking at people that didn't require any oxygen when they started the study. C is people just receiving regular flow oxygen. You can see that's actually the bigger difference. That's really where remdesivir had its effect. D is people that were on high flow or mechanical, high flow oxygen or non-invasive mechanical ventilation like CPAP or BiPAP. Maybe there's a small effect of remdesivir there. And then if patients were on mechanical ventilation, it was harder to see the effect. Now, when they did a multivariable look, there appeared to be some effect of remdesivir across the spectrum. But I think it's pretty clear that, and it makes sense, right? It's an antiviral for a respiratory infection. You need to give it earlier. I think we know that from influenza, and it's true for SARS-CoV-2. Next slide. We are developing oral therapy. This EIDD2801 is an oral therapy. It is also a inhibitor of the HIV RNA. It's actually causes lethal mutagenesis, which destroys the virus's ability to replicate. It does work it's an animal model. These are mice that are being protected if you give it quickly enough. Another example, if you give it within 12 hours, it has, works. The animals are really not impacted. But if you give it 24 hours, it has some benefit, but the animals clearly, some develop severe illness. So it, again, has to be given early. We're about to start a study of oral EIDD2801. at UNC. We're looking for people that want to volunteer. They have to be people that are recently diagnosed, but we would be very happy to consider referrals. Next slide. What about what's coming? Well, we have multiple antibodies directed at the spike protein, these monoclonal antibodies. We're also going to be testing them at UNC for treatment, and Mike Cohen will be testing them for prevention. And then convalescent serum. So the serum from recovered patients is being given. We've given it to about 50 people at UNC. There's early evidence that it has activity in comparative trials, so we're very, very hopeful for convalescent serum. It may depend on which convalescent serum you get, how high the titers are within the convalescent serum, and we're trying to study that. Next slide. I'm going to skip and just go on to talk about vaccine, and we can, if people have questions about antibodies, I can answer them. Next slide. So there are lots of people developing vaccines. There are at least 4 that are going to be studied in the US. These are 30,000 person studies. So they're big studies. We're going to be a site at UNC. We'll enroll between 500 and 1,000 people. Again, if you have people that are interested in participating in a vaccine study, we would welcome them. Next slide. There are a bunch of different technologies, which is actually good because if we have to vaccinate millions of people, and maybe more than millions, tens or hundreds of millions of people, you need the reagents to do that. It's not so easy. So that hopefully we'll have multiple active vaccines, though I think it'll probably be at least 18 months or more before we know whether we have one that works that can be distributed. Next slide. So just to summarize the treatment part, remdesivir works. It's modest activity, but it clearly works. And like most antiviral therapy, as I mentioned, starting earlier is almost certainly better. For vaccine, there's a race to start these trials. We hope to start as early as July at UNC with one of these big NIH trials. Can these monoclonal antibodies also work as prevention? Because older people do not develop good immunity with vaccines to respiratory viruses. So these monoclonal antibodies may be quite useful in the context of nursing home or nursing home outbreak. And then finally, if someone is infected or generates an antibody response to vaccine, will they be immune? And if they are, for how long? And those are open questions where we don't know the answer. So thank you for your time. I appreciate the opportunity to talk to you.
Thank you, Dr. Iran.
To Melissa.
Real quick, before we get started with Dr. Miller's presentation, I'd like to remind everyone, with the exception of our presenters, if you'll turn off your video feed, it slightly improves our audio. If you'll take a minute to make sure your video and audio are muted. And then also, if you're a participant or a provider that wants to get CME credit, please ensure that you have sent us your full name in the chat function if your name is not showing correctly when you log on. Thank you so much, and I'll turn it over to Dr. Miller.
Great, thank you so much. So this is a slide that should be familiar to you. You saw it just now in Dr. Iran's presentation. I'm just going to pause and say, can everybody make sure you're on mute? I'm actually getting a lot of static feeding through. Thank you. And so just to reiterate, the level of positivity that we see in nasopharyngeal high. We're talking about millions of copies of virus that are present there, which is one of the reasons why, I'm sorry, there's a large amount of static and feedback. Thank you. One of the reasons why, in addition to nasopharyngeal swabs, even though that's the specimen type we prefer, nasal swabs also are highly sensitive. I'm going to go on to the next slide since Dr. Iran covered this already. Here's an example of, even though pharyngeal, oropharyngeal and nasopharyngeal positivity rates are really early in disease, what we see in terms of, if you look at the chart on the left, days after onset of symptoms, it's really only the first week that the viral culture is positive. So even though we're still seeing a PCR-based test being positive, this is unlikely to be live replicating transmissible virus. In addition, you've heard, I'm sure, much about being able to detect SARS-CoV-2 RNA in stool. And while you can detect it in stool, and often for a much longer period of time than you might detect it in some respiratory specimens, it's also thought, at least in the majority of patients, not to be culturable and likely not transmissible by that mode of transmission, but still a lot of work to be done on this. Also at the top of the graph, you can see the timing of when patients seroconvert. So by about a week, about half of patients have positive antibodies, and then by 2 weeks, everyone in this study had positive antibodies. Blood and urine often are even PCR negative, and so these are not specimen types that we look for the RNA in our tests with. Next slide, please. For better or for worse, you know, the amount of RNA that's present in nasal swabs also means it's detectable for a long period of time, even though it might not be transmissible. This could be good in some ways because we're able to, in some ways, retrospectively diagnose patients even after they've been symptomatic for a week or so. But it's also bad in that we can't really use the test as a test of cure, for example. So in this slide, it summarizes, this is from the Emory residency program. They do a lot of nice pictographs like this to summarize different papers. And so you can see that in this particular paper, even by 4 and 5 weeks out after presentation with symptoms, you still had positive RNA results. And there have been reports, even though it wasn't in this particular study, of patients being positive 6 weeks or longer. We've had positive patients out 45 days or more. It does seem to be associated with the increased and prolonged viral shedding does seem to be associated with older age, diabetes, and hypertension. Culture was not done in this study, so there was no correlation to what was culturable and likely transmissible. Next slide, please. And so this leads, all of the data you've kind of heard so far leads to a model such as this in terms of which tests are helpful and which time of disease progression. So in the week prior to symptom onset, you're likely to have a positive nasopharyngeal swab, at least in those few days prior to developing symptoms. In those cases, you would also be able to detect the virus by culture if you did culture. And even by the time of symptom onset in a sputum or lower airway specimen, you would likely be able to detect the viral RNA. We're often not detecting using those specimen types until later in the course of disease. And if you follow these lines out, what you can see is in the pink line, the BAL and the sputum PCR is positive for much longer in the course of illness, as that blue line, the nasopharyngeal swab, goes away starting in weeks 4, 5, and 6. And so that's why we recommend, if it's later in disease, if a patient has not previously been diagnosed with COVID and they have a negative NP swab, that you either also collect an oral pharyngeal swab or collect a lower respiratory tract specimen such as a BAL or sputum PCR. If you look at that yellowish line that's there, that's the stool PCR, and this is getting to the point of while the levels are lower in stool, it does seem to have a prolonged detectability in stool. And then, of course, at the top, you can see where antibodies would be detected, and this is shown by the dotted lines, IgM and IgG curves. Next slide, please. So we have 3 tests that we're currently offering at UNC Medical Center. Their names are on the left. So the rapid test is the Cepheid Expert. This has been in the news by name and has been discussed as an accurate but rapid test to detect the RNA of SARS-CoV-2. So not to be confused with other rapid tests. So the Abbott ID Now, for example, is a point of care molecular test, but it has much lower sensitivity compared to this particular rapid test. And our big batch-based test can either be done by the Abbott M2000 system, again, not the ID Now, completely different system, and then our own laboratory developed test. So all of these have received emergency use authorization by the FDA and have been validated by our institution. And you can see in the specimen types, and I know there's a lot of abbreviations here, but upper airway and lower airway tract specimens, as well as the types of media that the swabs may come in. And we've had to do numerous validations. I've even lost track of the count at this point to be able to keep testing because of supply chain shortages, getting different swabs in, getting different media in from all over the state, really. And so we've had to try to be nimble in our ability to do all of these tests on the different specimen types. So the rapid test, the Cepheid test, it's about a 1-hour turnaround time. Here and at most of our affiliates, this is limited to inpatient, symptomatic inpatient and symptomatic ED to admission patients. That's because, again, of supply chain problems, and we have very little allocation of this test throughout the health system, UNC health system. All others, including asymptomatic screening, discharged patients, outpatients, and then tracheoaspirates, we only have approval to do on our own laboratory developed tests. But these batch-based tests, we offer a turnaround time of 24 hours or less. Next slide, please. To put this in a bit of context, so I have kind of our 2 main commercial tests and their limits of detection shown up here, and those are starred on this particular graph. But I've also included some of the reference laboratories and which are doing testing, and some of our clinics may be sending testing there, as well as the CDC assay, which was the first one to be available here under emergency use authorization. And the limits of detection. You can see that they vary a bit, but largely quite sensitive. The lab core limit of detection, that's really kind of the maximum one. That was kind of their worst specimen, which was a tracheoaspirate or a BAL specimen. They also have the CDC test at lab core, so not all of their tests have that high limit of detection, but all quite sensitive tests, and also approved for a variety of specimen types. Next slide, please. So the current state of testing here at UNC is we started with our own test the middle of March, and that was the only test that we had available at the time under FDA emergency use authorization. Shortly thereafter, there started to be commercial EUAs available, and so pretty much 2 weeks apart, we implemented 2 different commercial-based tests. And we are performing testing of different patient types for all UNC health entities. A lot of the affiliates also have a Cepheid instrument and is able to do some rapid testing on site to a limited capacity to get that short turnaround time when it's really needed. So our current capacity, we stated at this time, not really including the rapid testing numbers, because the numbers of those tests that we get vary week to week, and they're not big numbers. So we can do up to about 1,000 tests per day. So that being said, I just pulled our numbers for today. We've already resulted today at 12:30 when I looked 960 tests. So we'll definitely be over that 1,000 mark at some point today. Next slide, please. So where are we going? Actually, right now we have this instrument that you see on the slide being installed here at the medical center, and this allows us the capacity to do an extra 1,000 a day. It's very automated, and so tests will run throughout the day, having about a turnaround time probably closer to 8 or 12 hours. Rex has also put in a purchase order for this instrument, and we have a second instrument coming, and the timing of those is still to be determined. It looks like it might be August now, I'm hearing, instead of July. But with those instruments in place, the health system, and particularly the triangle part of the health system, will have about 4,000 tests per day that we can do. In addition, Rex has acquired another type of test that is a batch-based test that they were able to get about 8,000 tests ordered to do testing there. So they're looking at bringing that testing up as well. Next slide, please. So this is from the North Carolina state site that Dr. Iran mentioned earlier, and these were data from yesterday, and these are some of the indicators that the governor and DHHS have been looking at in terms of reopening and what phase that we're in. And so, one of the questions is, do we have the capacity to test between 5,000 to 7,000 people a day? And you can see over the course of the last month, the trajectory of the number of tests that we've been able to do as a state has greatly increased. And this is a very positive trajectory that we're seeing. We're also seeing a slight uptick in positive tests. It's certainly not going down. It's holding stable to going a bit up. We've certainly seen an uptick in our positivity rate just in the last week alone for symptomatic testing. And so we are still seeing a lot of COVID here in North Carolina. Next slide, please. These are the numbers for the health system, and this was as of yesterday morning, I believe. And so you can see here at the medical center, we've done almost, well, now we have done over 25,000 tests. And cumulatively among the affiliate laboratories, and the ones that you're seeing outside of McLennan Labs, those are all that rapid Cepheid tests that they have been doing on their site. And so they've done about 4,000 tests since we began testing for SARS-CoV-2. The positivity rates you see, there's a wide range of the positivity rate. Overall, it hovers between 5 and 8% for most sites. You do see some higher percentages for Wayne, Johnston, and Chatham Hospital, and this is largely, and it's consistent with what's being seen at the county level due to outbreaks in chicken processing facilities, meat packing facilities, prisons, and even some skilled nursing facilities. Next slide, please. This is testing here at the medical center, and so our positivity rate is shown in the navy color, while the number of tests resulted are in the shadow gray color on the graph. And you can see, you see that time between mostly in April that has that higher percentage and that jig up and down appearance that you see there. We were doing a lot of skilled nursing facility testing at that time, and so that kind of explains the sporadic positivity rate and higher positivity rates that we saw at that time. And around the beginning of May, you see that our positivity rate drops off. This was actually when we started doing a lot of asymptomatic screening. So both the volume of testing that we're doing, shown in the gray, has increased. Again, you see that positive trajectory over time, while the positivity rate overall has gone down, even though we're still seeing a lot of positive cases. Next slide, please. So probably the most common question I get asked, and I always joke and say, second to when is my test going to be available? And that's certainly true. That's the most common question the lab gets every single day. But a very common question is, what's the sensitivity and specificity of these tests? And I know that it's probably not satisfactory, because I'm going to say we really don't know. We're still learning a lot, and we know more than we did back in March, but we still don't clearly know the clinical sensitivity and specificity of these tests, in large part because we don't really have a reference method, and there's still not a clear definition of disease in terms of asymptomatic, pre-symptomatic versus symptomatic patients that are infected with SARS-CoV-2. So that complicates calculating the clinical sensitivity and specificity of it. What we do know is the analytic sensitivity and specificity of the test, and this is required by the FDA. If you'll forward to the next bullet, please. So as I mentioned, we have 3 tests. Between them, there are 3 different genes of the virus that we detect, even though most of them detect 2 genes in every single assay, and some of the targets overlap. We've seen 100% correlation of both positives and negatives between the 3 tests. all tests below 1,000 copies per mil of the virus, and we know they don't detect other coronaviruses in terms of like the endemic coronaviruses that we see every year, nor other respiratory pathogens. But I became very interested in this question in terms of can we get an idea of what the sensitivity is? You know, I hear people talking about, you know, the test missed 1 in 3 or it's 60 to 70% sensitive. And, you know, as a laboratorian that has developed one of these tests, that bothers me because that's not a great number. So to try to understand this a bit more, actually looked at our duplicate patient testing. So patients who were symptomatic, who were initially negative, but then at some point had a positive test. And when I did this analysis, there were 616 of those patients. And of those, only 4, so less than 1%, had converted within 3 days of the initial negative collection. Even if I took all comers and looked at everybody that converted and didn't put a time restriction on that, and again, that went out to 45 days of somebody that went negative to positive. So that could have been any number of reasons for that, including, you know, another exposure, something like that. So even including all of those, there were only 28. So less than 5% total conversions. So this suggests that the sensitivity of the RNA-based test is very high, and we estimate it to be about 95%, at least from what we know in symptomatic patients. We don't know a lot about how any of these tests perform in patients who are asymptomatic. Next slide, please. So in terms of antibody testing, we do also offer that in our immunology laboratory here at the medical center. And the numbers as of yesterday are shown there on the right. So just under 3,000 tests have been performed, and the positivity rate is very low, so 1.5%. So this compared to, I think, the New York numbers were about 20 to 25%. Some studies out of California have their percentage more like 5%. So it's unclear how antibody testing fits into any particular algorithm. At this point, it's not part of any of our clinical diagnostic algorithms, but we did implement it to support the state and looking in terms of what our prevalence is here and try to define what the clinical use might be. So I wanted to take the opportunity to take some of the data from the serology tests that are available, because you've heard a lot of them. There are hundreds of tests that have become available. Many of them are not, have not been reviewed by the FDA, and so they have a wide variety of performance characteristics. The tests are not the same. So I picked 2. The one on the left, the Abbott Alinity test, is actually the one that we do here at the medical center. And then the one on the right I picked is one that is a rapid lateral flow based test that I know has been marketed to a lot of physician practices. So if you look at the sensitivity and specificity, they're very good. So sensitivity for Abbott, 100, specificity 99. The Cellex test, almost 94% sensitive, 96% specific. But we have to remember how prevalence plays into positive and negative predictive values. And so these are from the FDA website, and I've included a link here. You can look or Google, try to find the FDA website. And it has this for many, many serologic tests. And, you know, they point out, you know, if you have a prevalence of 5%, this is shown on the bottom of those 2 tables, what the positive predictive value is. So you can see 84% and 55% respectively. But our positivity rate is 1.5%, so a much lower prevalence. So if I plug in the numbers for a 1.5% prevalence, the positive predictive value of the Abbott test is 60%, and the Cellex test is 26%. So even though the sensitivity and specificity look good because we have such a low prevalence right now, the likelihood of having a false positive is greater than having a true positive for some of these tests. Next slide. So antigen testing, I just wanted to comment on that. There is an FDA approved or emergency use authorized antigen test, the Quidel Sofia. This is in, you know, some of our clinic facilities, and a few of our institutions have used it for flu testing. It is antigen based, so not as sensitive as an RNA or nucleic acid based test, and the sensitivity has been shown. This is the FDA data shown on this site, but there have been a few publications since then that have corroborated sensitivities of 70 to 80%. And when it's compared to RNA-based testing. And so because of that, you know, I was initially very optimistic about having an antigen-based test, because obviously that's something simple to do. You can roll it out on large scale to get a lot of people tested. And I was optimistic, even knowing what I know about flu antigen-based testing, which I'm not a proponent of, but because there's so much viral content in the nasopharynx and in the nasal cavity, that I thought the antigen test might be more sensitive than that. So we may see that with additional types of detections of antigen, we can increase that sensitivity a bit. So I'm still optimistic that this could play a part going forward, but maybe not this particular test. And I believe that might be my last slide. So thank you, and I think we both be. This is a picture actually at the of the molecular microlab. Just the people that were in the room at the time when we resulted our very first run of SARS-CoV-2. So. Thank you for joining us today, and we'd be happy to answer any questions.
We do have a couple of questions that came through the chat box. The first is, where do we get more information about the studies available, such as the vaccine trial?
Sorry, my alarm's going off. We have a website, which I can give you the link that would give you more information. The vaccine trial is not up yet on the website, but it will be as soon as we have more detail about the start date. But I'll send that web link, and then we can have it circulated to the people on the call.
Thank you. Next question is, the IgG-AB test currently done at UNC specific to the SARS-CoV-2, or does it also detect IgG to other coronaviruses?
It is specific to SARS-CoV-2, and that's an important point. Some of these antibody tests, which you would see that specificity number on the FDA website would be much lower if it was a test that detected the seasonal coronaviruses. So we definitely challenged it against this, and it is specific to SARS-CoV-2.
And the last question that has come through is, how do we get information about the antibody trial?
Yeah, again, maybe they mean the vaccine trial, or the monoclonal antibody trial. Again, we will post all our studies on the web link that I'm going to give you right now. We have several treatment trials on the web link. As soon as we have information about the monoclonal antibody prevention trial, we will post it. But I will send that to, I'll send that out, and then it can get disseminated.
Thank you, Dr. Iran. Are there any other questions?
Don't be shy.
I do want to thank you all. I do want to let you know that this session was recorded. It will be posted later on the physician resources page of UNC Health, but it will not be available for CME for the recorded portion. But those that did also participate today will automatically receive a WebEx invitation for next week's COVID CME series presentation that will be Tuesday, June 16th at 12:30 for complications of COVID-19 infection, and that will be around pulmonary clotting, and then also nephrology. Thank you so much for participating.
Thank you.
Thanks, everyone.